So for this session, I would like to invite panelists, Dr. Vinit Talwar sir, Dr. Naveen sir, Dr. Satyanarayan sir, Dr. Chakor Vora sir, Dr. Swaratika ma'am, Dr. Amit Chaudhary, Dr. Vijay Simha.
I think it's a full-packed medical oncology session. Dr. Naveen, you from the medical oncology. Is it? Okay. Oh. So we'll just start this session, and we'll skip the adjuvant part of this because it's a metastatic RCC. So I think we'll start with quickly with one case, and then we'll take the discussion further. So 58-year-old patient presented with painless hematuria. Imaging reveals the right kidney lesion and a multiple bilateral lung mets of 1 centimeter, and the serum creatinine 1.2. Other labs are normal. ECOG PS1. So these are the baseline investigations, the routine one. So I will just like to ask with Vijay, what additional investigation apart from this you would like to do in this case? This is the CT scan picture, the renal mass with multiple lung metastasis in the CT thorax. How symptomatic is he for the hematuria? He had just the classical presentation like a hematuria, no other symptom. So on routine investigation, found to have a renal mass, and then further workup revealed the lung lesion, multiple lung lesion. So, to proceed with the therapy, obviously it's a renal cell carcinoma, and to risk stratify the patient, we will have to ask for the investigations which are relevant to the HIND criteria or the IMDC criteria. We need to know whether the inflammatory markers like elevated, whether there is. So these are already highlighted in that. So you are comfortable with this the parameters which are being highlighted. So these are the tests which you do. Apart from that, do you still feel? I think I will ask Swaratika that these are the criteria in standard practice we do, but how are their applicability in the current era, the immunotherapy? Are you comfortable? So if you look to the criteria, the type of the disease, the organ involved in the metastatic setting, and the burden of this disease has not been taken into consideration. So do you feel that these criteria are adequate in the current immunotherapy era? Basically, these were evaluated when the TKI were used. So do you feel comfortable using these criteria in designing, or do you still feel that there may be some improvement in this? That is the discussion which I want to.
Yes, sir. So one point is that the immunotherapy era is in the last 4 to 5 years. The curve which reflects favorable disease definitely requires a longer follow-up. So till we have that, we won't know exactly how reflective it is in the immunotherapy era. To answer your second question, I'm comfortable with the criteria in terms of weeding out high risk and intermediate risk disease. They very clearly presence of presence of anemia.
Suppose the patient has presented after 2 years with multiple liver metastasis,
yes,
and
sir,
all other parameters are normal. Do you comfortable keeping the patient in a good risk if our criteria fit? That is my question.
That's what's a high risk and intermediate risk. I'm comfortable. Good risk, not so much.
I think Dr. Talwar, you have the final say because you're.
So I think in the absence of good biomarkers, this is the only thing which we can bank on at this point of time.
Yes. So I think
there is a new criteria. I think.
Yeah.
Gupta
so this
criteria
is the one paper which I recently came to know about that. So definitely the things are moving very fast, and the current Hanks criteria might not be the appropriate, but in this study, what they have taken, they have given 1 point to each of the intact primary kidney tumor, liver metastasis, time, performance. So they have taken one of few criteria of the Hanks, and they have added one or two additionally. And in the end, what they find that these criteria, they and they compared with the survival for these persons, but they concluded that these criteria favored much more closely compared to the hang. So I think it's that this risk stratification is rapidly evolving, and in due course of time, we might get a different criteria from the what we do in a day-to-day setting of HINGs. So that means still we are not the HINGs criteria, or not the criteria for at least patients who are planning for immunotherapy. So how you will proceed in this case? Metastatic disease patient is comes into the intermediate risk. So Dr. Satyanarayana, what's your take call in this?
Sir, I will consider for IO along with TK.
So you don't have a tissue at this point of time. You have the CT scan shows the renal mass. So the question is, do we need to go for a cytoreductive, which is, I think, day-to-day issues with the neurosurgeons? Do you still want to, patient is asymptomatic for a hematuria? Do you want to go or some mild hematuria which has subsided? So do you want to go for a CT guided biopsy or USG guided biopsy? Or do you consider for or send the patient to the neurosurgeon for there? So that is the point of discussion I want to have.
So, in this patient, we will take the opinion from surgical oncologist.
And hematuria is not that it has settled down, or so hemoglobin is normal. It's not the massive hematuria which we have to push for that. So it's the usual. So do you still want to? So you still want to go ahead with cytoreductive nephrectomy? Amit, what's your take on call?
No, sir. Only CT guided.
You want to go ahead with CT? Don't want a patient is affording, so it's affording for everything.
Yes, sir. So I would, patient is asymptomatic. He's not having any pain or hematuria. So I will not go with the cytoreductive nephrectomy. I will start with the systemic therapy. And then after assessing the response, I will take a call regarding that, sir. After 9 to 12 weeks.
After 9 to 12 weeks.
Yes.
So I think, what's your take on call on this? So, so whatever the data, I think everyone is aware of the Carmina and Certime, the data. The one is the deferred cytoreductive nephrectomy, and one is the give TKI for some duration. Then, so do you still feel that this criteria should be taken into the consideration for immunotherapy or not?
So, sir, we do not have data in the immunotherapy era, first of all. So,
So
we will have
when
to
we
wait.
don't have a data, we have to take a call for that. So what you
So
will take a call? Do you
for-
want to go ahead with cytoreductive nephrectomy?
No, sir, not today. So
Not.
for if a patient is not symptomatic in the form of pain or hematuria, gross hematuria, I'll not.
Suppose this patient is not affording for immunotherapy and plan for TKI, then will your decision for doing a cytoreductive will change, or it will remain same?
There as well, there as Carmina and the other study, the Certime study, there was contradictory data from 2 different trials at that time. So the meta-analysis was showing positive results. So maybe there we can, but still it's not something that I practice as of now.
So I think Dr. Vinit is the most senior one. He will have a final.
If at all surgery, then I would defer it. I would do a interval cytoreduction, but given a choice, I would start with the IO plus TKI.
And if the patient is not affording for IU and only TKI, then still you want to go ahead with the same
Then
philosophy.
we want to go with the same, because even the pulmonary metastasis, they are small and they are multiple.
So I think that is one point which, so what the Carmina and Certime has, the evidence which they have produced is that as in a patient who is as such not much symptomatic, an interval approach might be a better way to deal with, rather than if the patient is in good risk, primary symptomatic for primary, then still otherwise you start the TKI, wait for a few times, see the response, and then interval. So that is one, but these are for the TKI era. Whether that is applicable for the immunotherapy era, the answer is still not known. So I think this was the data for Certime that the deferred was better compared to the upfront. But whether this is applicable, so this trial, this is ongoing study, which is the same way that the Certime has looked at the deferred nephrectomy, whether this approach is better or that. So the final answer will be, so that is the problem in oncology. When you come with a solution, by the time there is a next question to answer. So we have answered the cytoreductive nephrectomy in TKI era, and now the immunotherapy has come up. Whether that is so in a day-to-day practice, we start with the immunotherapy, which are not symptomatic. review after 4 to 6 months, and then if there is a very good response to the primary, then we discuss for doing a cytoreductive nephrectomy in this case. So I think Vijay, any takers for active surveillance? So theoretically, there are some papers and some 1 or 2 data. Swaratika, what's your take on call in this patient? Not very small lung nodule patient, not much symptomatic. Suppose there was no hematuria and the CT scan was done for abdominal pain, vague, and find a lung lesion, kidney lesion, and then a CT scan find it some lung lesion. So do you still consider active surveillance in day-to-day setting?
In TMH practice, I think the answer would have been much easier than the kind of practice I'm doing now. Simply because the kind of understanding the patient and the patient relatives need to have is immense. And and then it being backed up by a second opinion and a third opinion makes it even more difficult. So there is a patient who is asymptomatic for primary low burden disease, like few lung mets which are unresectable, and you have a favorable risk disease. There is data for active surveillance if the patient is willing to be compliant or has significant comorbidities, which make you
mean that
nervous to
in
use
some subset of the
TKI.
patient,
There is a subset.
then Dr. Vineet has the final words. So what for active surveillance, have you ever considered in any patients, or do you think that it's more of a theoretical rather than the practical problem?
Sir, as study have shown that IO plus
No, it's
TKI
not
can-
any, it's the real word. So do you want to discuss with the patient? Because at this point of time, I have able to convince only one patient in 10, 12 years I'm working in the Euro. So though theoretically it's indicated, but do you have considered any patient for that? What I want to ask.
Sir, definitely I will explain that both combination have overall survival benefit if they will have financial.
No, even for TKI, don't go for immuno. Even for a TKI patient is asymptomatic, TKI will have its own associated cost and the toxicity. It's not that they are not, they have its own. Amit, what's your take on call? You will refer to the Tata for next second opinion.
Sir, it is a very difficult call actually, sir. If the patient goes into visceral crisis or some kind of thing, then we become answerable for.
Chakur.
Sir, I totally agree with Swaratika and with you as well. Just like you have been able to convince only one patient in 12 years. So I had like 2-3 years back, I had told one patient for active surveillance, and he just like the family and everybody refuses. कि cancer पेट में बैठा है और आप क्या बोल रहे हो? So that way,
That is
the
difficult.
acceptance is not.
So I
there,
think
sir.
Dr. Vineet have the final say. Vijay, you want to add anything?
No, sir, because we cannot predict the biology, and it has more unpredictable biology. It's better that we begin treatment.
So my take would be 2 ways. One is the academic answer and the other is the India-centric answer.
India. I
So-
think that's a good sentence. India centric answer.
Yeah, because see, India compliance, a person coming from hinterland and you're telling him to come at this time and you do these tests. He has so many other things on mind. So because of paucity of compliance, I might be,
Are on the side of giving.
willing to treat the patient than to keep on surveillance.
So I think what the conclusion of this paper was that, so you have to select the patient. So what they concluded in this paper that if the patient who have, so the criteria which they have selected for their in patients who have a favorable, who falls in a favorable risk group with no or one IMDC factor. So even if you have to take a call, the patients who are who comes under a very favorable, so only one or none or one IMDC with 2 or few metastatic disease. So that is the patients who falls into the very favorable risk. In those you can consider, because the estimated median surveillance time was 20. So active therapy can be avoided for 2 years in this group of patient, where those patients who have a MDC more than 1 or more than 2 side of disease, this was only around 9 months. So from that, if you have to take a call, you can use this factor. But as you already said, It's very difficult, and medical legally it's very difficult to say that why you have not offered. So patient elderly, other associated comorbidities, ejection fraction 30%, asymptomatic. So in those group of patients still that can be considered. Otherwise, we consider for doing giving some sort of at least offering some sort of a therapy in all patients.
Sir, yours. Sir, in such a patient, wouldn't it be an oligometastatic approach as well?
Multiple
Multiple
metastatic site, multiple.
metastasis.
So this is the question. Next question is same. What you do in oligometastatic setting? So 2 or 3 bony metastasis or lung metastasis. What will be your approach? I think Vijay, quickly you can tell about that.
Sir, if a R0 resection can be adequately achieved, then definitely.
So I think and then offer adjuvant pembrolizumab in that scenario.
Yes,
That is
it will
what-
become a M1 NAD, and perhaps we can offer adjuvant pembrolizumab.
Suppose the patient have multiple bony 4 or 5 bony metastasis, then
No, sir, in that case, I
You
will
will
not be
not.
so comfortable.
Swaratika,
It was
but
only
take on call,
surgical.
because I find one of this paper that is very pertinent to our scenario. So I just want to have one quick discussion.
So I think it would depend upon the radiation oncologist confidence with SBRT.
They are
it
confident.
will-
If you send them, they will very rarely say no.
Yeah, but dealing with oligometastatic, if you're going to truly deal with it as oligometastatic and not not metastatic disease, it will depend on whether the lesions can be treated with adequate SBRT or not.
So you will go for the primary surgery and the SBRT related.
Followed by adjuvant therapy as well.
So even after RT, you want to consider adjuvant therapy?
Yes, sir. I would consider it.
Satyavan, the sir will be the last. He is the final authority.
Yes, sir. Same surgery followed by sir, along with the SBRT and adjunct pembro for 1 year.
Amit, same.
Sir, I will, after SBRT, I will rather, due to disease biology, I would prefer giving systemic therapy,
Which?
TKI.
How long?
IO. Means depending upon the tolerability and
But you have to define it. If you are planning adjuvant therapy, you have to
Yes.
define the duration. Adjuvant can't be lifelong. Na?
but
It's
we,
not like a breast cancer where you can go for 14 years.
so maybe 1-2 years, sir, but we don't have any
Chakor. So I think this was the paper which I was mentioning, that in this paper, they it's a phase 1-2 study. So after the primary surgery, they have done the the SBRT to the oligometastatic site. Then a short course of pembrolizumab for, I think in this paper, they have given for 8 cycles. So this may be some sort of useful to our patient population where the disease is limited. You have done the primary, you have given the SBRT, and then you do the 8 cycle. There is at least some data that we can stop at 8. So that is the problem with them. So that is one thing which we can practice in our setting, that in a oligometastatic, go for primary surgery, do SBRT, and then 8 cycle of a immuno. There may be some benefit in this group of the patient. So now comes the real Pandora box. I will just quickly go through systemic therapy in clear cell. So I think everyone is aware of this graph, and we multiple times discussed. So that is which phone to choose. All are there. So I think we'll discuss first with the intermediate risk and poor risk. So that is the question, that in real life, how many patients do you still consider for IO in first line? Quickly, everyone just have a flash of idea that how many patients of a metastatic RCC actually receives the IO?
I would like to consider in all, but practically end up in giving only in 10%.
10%. So Atika?
Agreed, sir, 10 to 20%. Even then, in those patients also who don't have insurance, I've given low dose nivolumab with cabozantinib.
So what is the evidence for low dose nivolumab?
No, there isn't. Sir. There is. I'm just saying, because in poor risk, like I said.
But then you should keep the data. But I can suggest that.
Yeah,
That's
what
whatever
it's
we are
early,
like.
yes.
So just pull the data, and if it is really
Yes,
benefiting,
yes.
definitely they should be
Yes,
promoted.
absolutely, sir. We are gathering, but there are 1 to 2 cases in between. So it's, we don't have that.
There are
bulk of
at least 100
TMH.
TMH alumni. If everyone contributes 2 cases, it will be 100 cases in a year. And Akhil may be very interested to keep that.
We have done a 5-year analysis of our RCC patients, about 800 patients. So it's about 12.5%.
So
for
slightly
IO.
better than the our setting.
But most of them are in second line, single agent.
Nivolumab. Your setting?
Sir, less than 10%.
10%.
yes, sir, less than 10%, sir.
Chakur,
Same, sir.
Same.
One
So I
in
think
10.
it's maybe single digit. So that is the real discussion, that though it is indicated, but Akhil can.
Where we would like to add immunotherapy, even if low dose if possible. So in
So
sarcomatoid
what I
RCC,
can suggest
low-
that whatever we are using, the I am also, but I think it's better to one of you take the responsibility and take the data, collect, and in a 1 year, 1.5 year, we can get the idea that how much it is really benefiting the patient. Then we can freely practice it with some publisher. Now we are extrapolating from the head and neck.
yes, sir. We have data of around 70 patients of low dose Nivo plus cabozantinib.
Yeah, that may be.
Pool, yes.
Yeah, so that will be really interesting to see how the real world practice that. And if we have 100 patient data of a low dose, which is more or less the PFS matching with the standard, that may be a very great benefit to the society. So I will just discuss quickly with this. So in a intermediate and poor risk, which are the group of the patient you will like to choose for IO? Cost is not a constraint. How you will decide IO versus IO plus TKI? So what are the factors? I think Vijay, you can start. So which regime you will prefer in an intermediate and poor risk patient is not, but is affording for everything.
Sir, when the patient presents to me, the response rate is the #1 criteria in front of me.
So
when
that
I
is the
decide.
established thing that
So
apart from
if I
that,
want a response, then absolutely I would prefer a TKI with immuno-oncology.
immunotherapy. Do
But
you,
if-
do you
if the
not
patient-
want to consider the long-term data for this, the 42 months, because among, if you see all the options, the longest data for this is with IO plus IO. Do you want to ignore that or not?
Sir,
So you still want to go ahead with IO plus
yes, sir. Yes, sir.
TKI?
yes, sir, but
Swaradhika?
the best chance of cure, of course, would be with IO.
So definitely in poor risk patients who have TKI tolerance issues, or even if I, like if they have cardiac issues, if I predict Stoughton might be
Everything is
difficult to
formal.
get.
Patient is totally fit. Patient has some relative in the US.
No, sir, I think there is enough data to suggest and offer the patient Nivo plus ipilimumab. Ipilimumab has only 4 doses. After that, it's nivolumab, a single agent. It prevents TKI, chronic toxicities, sugar control.
Yeah,
Some
so you
issues
would
become
like to
better.
consider.
I would like to
Satyavan,
consider that, sir.
your call. Dr. Vinny, at the last, you are the final sentence you have to.
Sir, Nivo
I
plus
think we are
EP,
8 minutes. So
Nivo plus EP.
Nivo EP, if patient is affording. Amit,
Nivo EP, sir.
so how, Chakur?
My preference is IO plus TKI, sir.
But
My
in the
first-
practice, how many patients have you able to, so out of 100 patients who are affording for IO plus IO or IO plus TKI, how many patients end up you are considering giving IO plus IO? Percentage wise?
None actually till now. So
I think Dr. Vinit will be, he is sitting at a center where cost doesn't matter.
No, you only quantified that cost is not an issue.
So you ultimately the patient says, family says, then they
Yeah.
you decide.
So the
So how
issue
you
is
decide?
IO plus IO versus IO
IO
plus
plus
TKI. So when you think about that, you have to think about 2-3 parameters. One is the CR rates, second is the response rates, and durability of response and the depth of response also. So the depth of response is with Cabo-Nivo. The durability of response is with Ipi-Nivo. And if you take at maximum CR rates, it is with the Len and PEM, right? But then if you have maximum CR rates, but does that translate into durability? Answer is no,
Yes.
because they wither out after 1.5 or 2
Yes.
years. So we have the data with Ipi-Nivo that even after 5 years, you have 25% of patients who are still living and disease-free. So I think the durability of response in my
Yeah.
thought
Yes.
would be the best
So
criteria.
I think this slide, but the follow-up data, it says that if you see this, so 42 months, so around more than 50% patients are still surviving. So that is the real benefit. But definitely giving IO plus IO, slowly we are learning, but definitely the toxicity management is which I will discuss. And this is the same slide, the same the depth of. So around if you see this 28 patient, that is 47 of the patient who have a complete CR. 28 patients have never not received any subsequent therapy. So I think that is the very compelling to think for a IO in day-to-day setting, that some patient who achieve CR, out of them 50% may not require till now any subsequent therapy. So I think, what about this issue, the early progression? So is it really a common challenge for selecting a patient in day-to-day setting? Dr. Vinith, you can be right person to comment on that. The early progression, that is the problem which is being many times quoted in the literature for the IO plus IO use.
Well, if you see the graphs of say PEM and AXI versus Ipi-Nivo, you find that in the initial phase, they're almost similar for about 6 to 8 months if it is Ipi-Nivo. Whereas in PEM AXI, where the TKI is there, you find there is a, a spacing of the graph. So if you give IO plus IO, that is the critical period, in the first 6 to 8 months. If the patient progresses or not, that is the only caveat. Otherwise, I think you can argue it both ways.
So
the other thing is that even in the intermediate risk, intermediate 1 and intermediate 2 are totally different. If you see, as a post-hoc analysis of Carmina trial, the intermediate 1 was as good as good risk. So there may be some patients who may have an indolent disease, but they are clubbed in the intermediate risk, and you say that, this patient is going to do poorly, but in actuality, it doesn't.
So I think this is the slide finally. So the benefit of the Ipi-Nivo, that it has a highest follow-up around 55 months, and the benefit of which was discussed by the PFS is quite amazing, 24. Whether this will transform into the OS, we have to wait for this data. And definitely the CR rate is highest seen with that. So I think among all the TKIs, if the long-term follow-up data suggests that, I think Len-PEM may be some superiority, which we have to just wait for till the long-term data matures. So I think we'll just skip with this. So I think that has already discussed, and this is just showing the responses rate. So I will just skip. So now come the triplet regime. Any takers for the triplet regime till this point of time, Dr. Vinith? So do you think that this is going to be the game changer? IO, NIPI plus Cabo. So in our country, we are giving 40 mg Cabo is a big headache. Whether to combine Ipi-Nivo with Cabo, how much is really going to be the?
So again, here we have the DFS.
Till this time, suppose this regime, turns out to be giving the OS benefit. How comfortable you are using this regime in day-to-day setting?
So the fitness of the patient, that would be the most important criteria. And second question would be the obvious question. You give this, the patient progresses, then what?
But I'm not sure how much we will be able to deliver the Cabo. Giving Cabo 40 is a problem in our setting. So combining Ipi-Nivo with Cabo, I'm not sure. We have to just see. So what also, so that was the, so what we can conclude that IO plus IO in a selected group of the patient can be some sort of a curative. Otherwise, IO plus TKI if the patient is not, or if the disease burden is more, then we can. What about good risk or favorable risk RCC? Do you want to consider single agent TKI or IO plus TKI? I think Vijay, we can just conclude.
Prefer to go with IO plus TKI.
Even in good risk. Although if you see this graph,
the benefit is yes. Sir.
Yeah, if you see the favorable risk details, so even the OS, the PFS, all the hazard ratio is crossing. Although it's not the right way to see the graph, but still.
But subset analysis of a
but still, so you want to, Dr. Vinith, in a good risk or a patient or favorable risk, IO plus TKI or IO alone?
So
TKI alone.
You are giving me the money, or
patient is affording?
Patient is affording.
Yes.
All your patients are affording. So, well, if the patient is affording, then I'll give him the best PEM plus IO plus TKI.
So any reason for selecting the IO plus TKI over the TKI alone?
So data shows that if you give only TKI and if you give IO plus TKI, the results are much better.
But in the good risk, there, but I'm not very sure. What about others?
Sir, in good risk, if low disease burden is, then can consider for surveillance or TKI alone, or substantial disease burden is there, then combination can be considered.
Amit, same.
Yes, sir.
So I think just skip with that. So I think the other thing which is in a patient who is not affording for the IO plus TKI, which will be your first TKI? Whether, so do you have changed our practice with this data? In an intermediate and poor risk not affording for IO, do you want to use sunitinib, pazopanib or cabozantinib?
Cabozantinib, sir.
Swaratika?
Sunitinib.
Sunitinib. Even though this data,
Yeah, in the absence of, I find myself being more comfortable with student accesses. I mean, it's my personal preference.
personally. Dr. Vineet?
Well, given this data, I would be tempted to give cabozantinib than sunitinib.
So what is the starting dose of cabozantinib in your practice, 60 or 40?
So I start with 60, but data says that even if you give 40 milligrams, it is not inferior.
So how comfortable with 60? Because I find it very difficult to start with 60. Not sure.
Ultimately, you gravitate to 40.
So I think that is the one point of discussion, that even if you see the toxicity around the second line. And so quickly, we'll just want to discuss this. So what will be the second line of choice when patient has utilized the IO plus TKI or IO plus IO in first line? Vijay?
With careful addition of everolimus, and I would.
So
say
len
very
plus
careful-
Avro is your choice.
Everolimus is very optional.
Same, sir.
Same. Dr. Vineet, second line.
I might give cabozantinib also, because there is
Yes.
one trial, cantata trial, in which you have that's a tongue twister, that plus cabozantinib versus cabozantinib
Alone.
only. So although it was a negative trial, but still, if you gave cabozantinib alone in those patients who have been exposed to IO, there was a PFS of about 9 months,
Yeah,
which
so-
is quite significant.
So what I want to discuss that even if this, so what we do in practice, if the patient has a long-term benefit with the patient has supposed to receive the TKI alone, if a good benefit with TKI, then we can use the second line TKI. Otherwise, len plus. If you see the OS, more or less is in the range of 20s in also.
Len or everolimus, I would put it for the third line.
Third line. So I think second line will depend upon what was the response of the initial first line therapy. So I think just discuss that is this value-defend. This is on the verge of this HIF factor, and it's a very good data. And I think in next or 1 or 2 years we will get the this value-defend as a second or third line. Similarly, this tivozanib that is just on the verge of is already approved in third line, but we don't have in India. But if you see the data of tivozanib, seems to be active even on the third line also. So I think we'll just this will be the last question. Then we'll stop. So regarding the immunotherapy toxicity, not very much discussed. So how commonly you see the immunotherapy toxicity grade 3-4, which requires in stoppage of the treatment and the use of a strike? How comfortable you are, Vijay? Just quickly, then we'll just sum up the round. So we are discussing more and more immunotherapy, but the real problem, what we are facing, that these are the drugs which are not very simple drugs. Sometimes.
Most commonly endocrinopathy is what we've seen, sir.
So how many
Otherwise-
patients you stop the treatment and you destroyed? And which is the worst toxicity which you have experienced?
Worst toxicity, actually, in my practice, we had one case of myocarditis, sir. We had one patient.
Yes.
So that was the worst
Worst
toxicity that we
toxicity.
had faced. Otherwise, most commonly it is endocrinopathies that we have seen.
Swaratika.
So worst toxicity has been pneumonitis and myocarditis. Myocarditis patient was actually, we lost that patient finally to cardiac failure. But it's still, most of the patients do tolerate. Most important side effect in the clinic has still been fatigue. And then it becomes very confusing as to whether it's the TKI or the IO which is causing the fatigue.
Dr. Vineet, how many patients do you
I think,
have to stop?
Almost the same as they've told. Endocrinopathies are there. One patient I had to stop because of pneumonitis, pulmonary pneumonitis. And he had COPD. It was very difficult to
Differentiate.
judge what is what, but then ultimately he succumbed because of that.
Yes, sir, same.
So I think what the
he-
panel discussed, so around 10 to 15% patient will land up in a some or other complication and will require some sort of steroid. So that we have to keep in the mind that these are the drugs, although safe in majority of the patient, but in some odd patient you will get the difficult time, and you should be mentally ready to prepare. So I think in the best interest of time, I will just so this is one graph which I like to show every time whenever I get a case. So if you see the survival, how it has improved from the interferon era, the survival was in the range of around 20% patient used to come to the survival for around 10 months. But if you see these are the graph which are going, so the combination of TKI, see how the improvement has done. So the 3-year survival is close to the range of 70, and that's what we are looking for. This should be a flat curve. So all patients who are diagnosed with metastatic will have a long-term survival, and definitely with the availability of the TKI and this bar has gradually improving over time. So I think I will just end up with that, and thank you all the panelists for this wonderful discussion, and thank the organizer for giving the topic.